Schizoaffective disorder is typically diagnosed in clinical practice. However, its conceptualization in terms of its position alongside schizophrenia and mood disorders varies significantly. The diagnosis of schizoaffective disorder has been considered notorious for its low diagnostic reliability, both test retest, and interpreter, and substantial diagnostic shift. The exact prevalence of schizoaffective disorder is not available. It is presumed to be one-third of that of schizophrenia, that is 0.3% of the general population. Now coming to the history of schizoaffective disorders. So Jacob Casanin, he was the first to coin the term schizoaffective psychosis to identify patients with characteristics of both schizophrenia and mood disorders. He based his observation on a distinct subgroup of 9 young patients with good pre-morbid functioning, a sudden onset of both schizophrenic and mood symptoms, and a good outcome. However, a review of his detailed case histories shows that all of these individuals could have been diagnosed as having a mood disorder with psychotic features under the DSM classification. Now coming to the development of the concept of schizoaffective disorder. So Jacob Casanin, he was an American psychiatrist who coined the terms schizoaffective psychosis in the United States of America in 1933. Now, even before 1933, this schizoaffective psychosis, this disorder was described by various psychiatrists in Europe by various other names. For example, Carl Kolbohm, he described this disorder as Visania typica circularis, that means typical circular insanity. Then came Emil Kraepelin. Emil Kraepelin was also very familiar with the cases in between dementia precox and manic depressive insanity. In his article, The Phenomenological Forms of Insanity, he had said that mental disorders can have elements of both groups, dementia precox and manic depressive insanity, and he saw a weakness in his dichotomy concept. He said that these cases which are not classifiable are unfortunately very frequent. Now, Bleuler described them as mixed psychosis, and a colleague of Bleuler, Jules Angst, in 1966, described them as schizoaffective disorders. Now, Schneider described them as cases in between. And what we actually call schizoaffective disorders was described by Kurt Schneider in a similar way as cases in between, whereas what Casanin described was more similar to what we call today as acute and transient psychotic disorders. Now, the modern concept describes schizoaffective disorders as concurrent or sequential. Now, let's come to the theory of continuity of mood disorders. Now, there can be a bipolar course or a unipolar course. So, affectivity, when there is hyperthymic or cyclothymic temperament, that would lead to hyperthymic and cyclothymic personality disorders, cyclothymia, hypomania, bipolar 2, bipolar 1, mixed affective bipolar states, psychotic bipolar, schizoaffective bipolar and cycloid psychosis, and mixed bipolar schizoaffective states. Whereas a depressive temperament would lead to depressive personality disorders, dysthymia, mild depressive episode, melancholia, psychotic depression, and unipolar schizoaffective psychosis. Now let us come to what are concurrent and sequential types of schizoaffective disorders. As the concurrent type of schizoaffective disorders, we define disorders as having only schizodepressive, schizomanic, or schizomanic schizodepressive mixed episodes. This means that there is a coincidence of schizophrenic and affective symptomatology at the same time. Whereas the sequential type, we define schizoaffective disorders under a longitudinal aspect. Basically, concurrent type describes it as a cross-sectional concept and sequential as a longitudinal aspect, namely those disorders with a change of different episodes for schizophrenic, depressive, manic, schizodepressive, and so on. Now, the prevalence. Schizoaffective disorders appears to be around one-third as common as schizophrenia. Lifetime prevalence is estimated to be 0.3%. Now, the incidence is said to be higher in males because of an increased incidence of depressive time among females. Now, etiology and risk factors. Etiology of various psychotic disorders overlaps considerably, and schizoaffective disorder represents an epitome of such an overlap. All the etiological models proposed for schizophrenia more than mood disorders apply to schizoaffective disorder as well. Owing to the problems related to the diagnostic construct of schizoaffective disorder, implying specific etiological models to it is challenging. Now, neuroimaging studies have been done that reveal that the abnormalities found in patients with schizoaffective disorders resemble more of schizophrenia than of bipolar disorder. Now, these abnormalities were seen as increased ventricular volumes, widespread gray matter volume reductions, hippocampus volume reductions, and thalamic space deformations, shape deformations. Similarly, impairment in cognitive functions, namely working memory, attention, memory recall, and verbal learning, abstract ability, and motor planning found in patients with schizoaffective disorders resemble patients of schizophrenia. Although very little certainty with regard to genetics of schizoaffective disorder exists, variations in genes regulating circadian rhythms and neuronal migration during early development, especially the gamma-aminobutyric acid receptor genes, are implicated to denote high risk. The risk of a non-twin sibling being affected is 5%, despite a twin concordance of 40%. Although the exact inheritance pattern of schizoaffective disorder is unclear, the overall risk of developing the disorder is higher in first-degree relatives of those diagnosed with it. There is a substantial familial overlap with both schizoaffective and schizophrenia and bipolar disorder. A family history of depression, bipolar disorder, and schizophrenia is found in many patients who receive a diagnosis of schizoaffective disorder. Now coming to the most important part of the discussion, comparative nosology. Now, schizoaffective disorders as a diagnostic entity appeared in all the versions of DSM, and with each revision of the DSM, the diagnostic position of schizoaffective disorder has varied. Conceptually, the DSM classification system describes schizoaffective disorder as a concurrent presence of both schizophrenia and mood disorder, with the mandatory criteria of schizophrenia symptoms to be present for at least 2 weeks in the absence of prominent mood symptoms that have established itself. Basically, DSM has defined it as a uninterrupted illness where both schizophrenia and mood disorder should be present concurrently at the same time. And the symptoms of schizophrenia should be present for at least 2 weeks, even in the absence of mood symptoms, whereas ICD has classified schizoaffective disorder as an episodic disorder where affective and schizophrenic symptoms are prominent within the same episode of illness. Although co-occurrence of symptoms of schizophrenia and mood disorder was mandatory in the DSM, ICD was a little lenient by stating preferably simultaneously. Although any affective symptoms presenting with schizophrenia symptoms are enough for an ICD diagnosis of a schizoaffective disorder, DSM has stated a stricter major mood episode in its criteria. Although the DSM conceptualizes its diagnosis based on a longitudinal course, ICD focuses on it as a cross-sectional observation. Now we'll come to the individual nosology as per DSM-5, ICD-10, and ICD-11. So first of all, as per DSM-5. Now the diagnostic criteria of a schizoaffective disorder as per DSM-5 states that an uninterrupted period of illness during which there is a major mood episode, that is major depressive or a major manic episode concurrent with the criteria A of schizophrenia. Now criteria A of schizophrenia as per DSM includes hallucinations, delusions, abnormal behavior, disorganized speech, and negative symptoms. So these 5 present for a period of 1 month should be present along with a major mood disorder, which can be manic or depressive, uninterrupted. And it also states that the major depressive episode should include criteria A, that is, a low mood should be present to call it a depressive illness, because it has been seen that even negative symptoms of schizophrenia can show anhedonia. So anhedonia is not counted, and low mood should always be present. Now, delusions or hallucinations for 2 or more weeks should be present in the absence of a major mood episode during the lifetime duration of the disease. Symptoms that meet the criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the disease. Now, the criteria B differentiates it from mood disorders with psychotic symptoms, because here the psychotic symptoms should be present even when the mood symptoms are not present. And according to the criteria C, it says that the majority of the illness should have a mood disorder. The mood symptoms should be of more duration than the schizophrenic symptoms, and the disturbances are not attributable to the effects of a substance or any medical condition. Now, the specifiers to it are bipolar type and depressive type, and or with catatonia. The subspecifiers are: the following four specifiers are to be used only after a 1 year duration of the disorder, and if they are not in contraindication to the diagnostic course criteria. So, first episode, currently in acute episode, that means first manifestation of the disorder, meeting a defining diagnostic system and the time criteria. An acute episode is a time period in which this symptom criteria are fulfilled. Then first episode, currently in partial remission. Partial remission is a time period during which an improvement after a previous episode is maintained, and in which the defining criteria of the disorder are only partially fulfilled. In full remission, no disorder specific symptoms are present. Then there can be multiple episodes. Currently in acute episode means multiple episodes may be determined after a minimum of 2 episodes. That is, after a first episode, a remission, and a minimum of 1 relapse. Then multiple episodes currently in partial remission, multiple episodes currently in full remission, and continuous. Continuous is symptoms fulfilling the diagnostic symptom criteria of the disorder are remaining for the majority of the illness course, with sub-threshold symptom periods being very brief relative to the overall course, and unspecified. Now coming to ICD-10. Now, according to ICD-10, schizoaffective disorders are episodic disorders in which both affective and schizophrenic symptoms are prominent within the same episode of illness, preferably simultaneously, but at least within a few days of each other. Their relationship to typical mood disorders and to schizophrenic disorders is uncertain. They are given a separate category because they are too common to be ignored. Patients who suffer from recurrent schizoaffective episodes, particularly those whose symptoms are of manic rather than the depressive type, usually make a full recovery and only rarely develop a defect state. Now, the diagnostic guidelines as per ICD-10. A diagnosis of schizoaffective disorder should be made only when both definite schizophrenic and definite affective symptoms are prominent simultaneously or within a few days of each other within the same episode of illness, and when, as a consequence of this, the episode of illness does not meet the criteria for either schizophrenia or depressive or a manic episode. So the difference here from DSM is that here definite affective symptoms are written and definite schizophrenic, whereas there the diagnosis should be fulfilled of a major mood episode, and there a stricter time frame is there. Here they can be prominent simultaneously or within a few days of each other. The term should not be applied to patients who exhibit schizophrenic symptoms and affective symptoms only in different episodes of illness. It is common, for example, for a schizophrenic patient to present with depressive symptoms in the aftermath of a psychotic episode, post schizophrenic depression. Now, schizophrenic disorder, schizoaffective disorder in the ICD-10 has been classified into a manic type and a depressive type, whereas in DSM-5 it was classified as a bipolar type and a manic type and a depressive type. So, schizoaffective disorder manic type, there must be a prominent elevation of mood or a less obvious elevation of mood combined with increased irritability or excitement. Within the same episode, at least one and preferably two typical schizophrenic symptoms as specified for schizophrenia diagnostic guidelines should be clearly present. Now, at least one or two typical schizophrenic symptoms must be present out of from A to D, that is thought echo, thought insertion, withdrawal, thought broadcasting, delusions of control, influence, or passivity, hallucinatory voice, second and third person auditory hallucinations, and persistent delusions of other kinds that are culturally inappropriate and completely impossible. This category should be used both for a single schizoaffective episode of the manic type and for a recurrent disorder in which the majority of episodes are schizoaffective manic type. Now, schizoaffective disorder depressive type. There must be prominent depression accompanied by at least 2 characteristic depressive symptoms or associated behavioral abnormalities as listed for depressive episode. Within the same episode, this is the same criteria as manic one. Within the same episode, at least 1 and preferably 2 typical schizophrenic symptoms should be present. And this category should be used both for a single schizoaffective episode depressive type and for a recurrent disorder in which the majority of episodes are schizoaffective depressive type. Then we have other schizoaffective disorders and schizoaffective disorder unspecified. Now coming to ICD-11. Now, according to ICD-11, all diagnostic requirements for schizophrenia are met concurrently with mood symptoms that meet the diagnostic requirements of a moderate or severe depressive episode, manic episode, or a mixed episode. In making diagnosis of a schizoaffective disorder depressive episode, it should always include depressed mood and not just diminished interest or pleasure. The onset of a psychotic and mood symptoms is either simultaneous or occurs within a few days of one another. The duration of symptomatic episodes is at least 1 month for both psychotic and mood symptoms. And the last criteria is same. The symptoms or behavior are not a manifestation of any other medical condition and are not due to effects of any substance or medication on the central nervous system, including withdrawal effects. Now, the core specifiers and sub-specifiers as given in ICD-11 are single episode, multiple episodes, and continuous. Then it has given currently symptomatic, in partial remission, in full remission, and unspecified. So there can be single episode with these 3, multiple episodes with these 3, and continuous episode with these 3. So currently symptomatic means all diagnostic requirements for schizoaffective disorder in terms of symptoms and duration are met or have been met in the past 1 month. In partial remission means the full diagnostic requirements of schizoaffective disorder have not been met within the past month, but some clinically significant symptoms remain, which may or may not be associated with functional impairment. In full remission, the full diagnostic requirements of schizoaffective disorders have not been met within the past 1 month, and no clinical significant symptoms remain and unspecified. So schizoaffective disorder first episode. The first episode specifier should be applied when the current or most recent episode is the first manifestation of the schizoaffective disorder, meeting all diagnostic requirements in terms of symptoms and durations. If there has been a previous episode of schizoaffective disorder or schizophrenia, the multiple episodes specifier should be applied. Then as discussed in the previous slide, it can be further classified as first episode currently symptomatic, in partial remission, in full remission, or unspecified. Now, schizoaffective disorder, multiple episodes. The multiple episode specifier should be applied when there has been a minimum of 2 episodes meeting all the diagnostic requirements of schizoaffective disorder or schizophrenia in terms of symptoms, with a period of partial or full remission between episodes lasting for at least 3 months, and the current or most recent episode is schizoaffective disorder. Now, there was a note here that the 1 month duration requirement for the first episode does not necessarily need to be met for the subsequent episodes. During the period of remission, the diagnostic requirements of schizoaffective disorder are either partially fulfilled or absent. Now, it can be again further classified as currently symptomatic, partial remission, full remission, and unspecified. Now, schizoaffective disorder continuous. The continuous specifier should be applied when symptoms fulfilling all diagnostic requirements of schizoaffective disorder have been present for almost all of the course of the disorder during the person's lifetime since its first onset, with periods of sub-threshold symptoms being very brief relative to the overall course. It was also written that periods of partial or full remission have been very brief relative to the overall course, and none have lasted for 3 months or longer. In order to apply this specifier to a first episode, the duration of schizoaffective disorder must be at least 1 year. In that case, the continuous specifier should be applied instead of the first episode specifier. Now, the others are other specified schizoaffective disorder and schizoaffective disorder episode unspecified. Now here, this table shows a comparison between DSM-5 and ICD-11. So DSM-5 followed a more longitudinal approach and subtypes were bipolar and depressive, and ICD-11 followed a more cross-sectional approach, subtypes were manic, depressive, and mixed. In DSM-5, mood and psychotic symptoms are present concurrently, and in ICD-11, mood and psychotic symptoms are present concurrently or within a few days of each other. DSM-5 showed there was said that there should be a major mood episode, and according to ICD-11, a moderate or severe depressive episode, manic or mixed episode should have been present. Criteria A of schizophrenia should be met in DSM-5, and in ICD-11, all features required for schizophrenia should be met. And in DSM-5, delusions and hallucinations for 2 or more weeks in the absence of a major mood episode during the lifetime duration of the illness are the criteria, and ICD-11 has no such criteria. Now coming to the developmental presentations. The diagnosis of schizoaffective disorder among children is challenging because the sequence of mood and psychotic symptoms may be difficult for children to accurately describe. Children diagnosed with schizoaffective disorder are the most severely impaired and have the poorest outcomes amongst all children diagnosed with psychotic disorders. Schizoaffective disorder with manic episodes is more common among young males, whereas schizoaffective disorder with depressive episodes is more common among older adults. Now, assessment by clinical scales. So, no symptom rating scale has been developed and validated to rate schizoaffective disorder by now, till now. Now, scales which can be used are the PAN-SS score, the HAM-D score, and the YMRS score to rate symptoms of schizoaffective disorder. However, there was one scale, the Clinical Global Impression for Schizoaffective Disorder, that has been specifically developed and validated. Now, let us come to the treatment of schizoaffective disorder. So, the approach to treatment. The treatment of schizoaffective disorder has to be individually planned. Subsequent to diagnostic evaluation, the treatment plan involves the following steps: determining the disorder subtype, that is whether it is bipolar or depressive, then the phase, acute phase or maintenance phase, and the goals of the treatment. Then selecting the specific treatment strategy and evaluating the predictors of outcome. So the illness subtypes to be determined are bipolar and depressive. What is acute phase? It is this is when patients are acutely symptomatic, either first episode or relapse, and have acute and severe mood or mood disorder or psychotic symptoms. That is till they have reached a sustained remission. Maintenance phase can be described as this phase begins when the psychotic and mood symptoms are reasonably well controlled and clinical remission has been established to have sustained. The primary goal of this phase of treatment should be to aid the patient in returning to pre-moderate functioning and preventing future relapse. Accordingly, the goals of this phase of treatment are primarily to reduce the severity of psychotic and or affective mood symptoms, and secondarily to reduce and prevent the associated symptoms of agitation, aggression, violence, and self-harm. And ancillary goals should also be to formulate treatment plans, both short-term and long-term, during this phase of management. Now, there are two types of therapy, non-drug therapy and drug therapy. So first of all, non-drug therapy and supportive care. Specific treatment strategies, psychotherapy. During the acute phase of treatment, supportive therapy may be beneficial as an adjunct to pharmacotherapy. In the maintenance phase, various modes of psychotherapy, both individual and group and patient and family, that are indicated for mood and psychotic disorders may be applicable to schizoaffective as well. Patients' psychoeducation, a model suggested by Colomb and Vieta for bipolar disorder, has been suggested to be beneficial during the maintenance phase for both bipolar and depressive subtypes of the schizoaffective disorder. Especially psychoeducation to caregivers is beneficial in improving treatment adherence. The choice has to be driven by individual clinical presentation and stage-specific functional challenges. Patients prefer interventions that focus on early readjustment to daily activities and are recovery-oriented. So now coming to the drug therapy of the schizoaffective disorders. So antipsychotic drugs combined with mood stabilizers, which can be lithium, valproate, lamotrigine, or carbamazepine, are the most prescribed, 54%. A combination of antipsychotics was the second most commonly prescribed, 13.95%. Antipsychotic monotherapy was the third most commonly prescribed, 11.9%. And a combination of antipsychotic, antidepressant, and a mood stabilizer was prescribed in 5.9% of patients. Now we'll describe the treatment for the bipolar type and the depressive type. And in bipolar and depressive, both we'll talk about the acute phase management and the maintenance phase management. So first of all, bipolar type acute phase. So antipsychotic monotherapy. So paliperidone is the only approved FDA agent for the treatment of schizoaffective disorder, and also risperidone. They have the best, that is 1+ class of evidence. For paliperidone at lower doses, improvement is restricted to manic and depressive symptoms. At higher doses, paliperidone improves positive and negative symptoms of schizophrenia and affective symptoms. Now, risperidone and olanzapine too are effective for psychotic, depressive, and manic symptoms. Among the first generation antipsychotics, it was haloperidol that showed equal efficacy to risperidone in treating psychotic and affective symptoms, and in treatment-resistant cases, clozapine revealed marked improvements. Clozapine also showed effectiveness for suicidality. Now, mood stabilizer plus an antipsychotic. This combination treatment is deemed to be the best possible treatment strategy. Risperidone, when added to mood stabilizers, specifically lithium or carbamazepine, is effective for manic, depressive, and schizophrenic symptoms. Haloperidol can be given in combination to lithium, and clozapine combined with lithium is also more effective for positive symptoms as well as and effective as clozapine and a placebo for negative symptoms. Now let us talk about the maintenance phase of bipolar type. The antipsychotic monotherapy, the best available class of evidence is 1+ for the therapeutic use of once monthly paliperidone long-acting injectable. It has been found to be associated with greater time to relapse for psychotic, manic, and depressive symptoms. Similarly, long-acting injectable formulation of risperidone has similar efficacy and association profile despite only 1- class of evidence. Other antipsychotics in oral formulation which were found to be effective as monotherapy were aripiprazole, quetiapine, risperidone, olanzapine, fluphenazine, and clozapine. In patients with schizoaffective disorder who responded to clozapine during the acute phase, clozapine has been found to be effective during the maintenance phase as well. Therefore, the recommended is the use of antipsychotic monotherapy, especially atypical antipsychotics in the maintenance phase treatment of bipolar disorder, that is paliperidone or risperidone long-acting injectable once a month. Now, mood stabilizer monotherapy, only lithium and carbamazepine have been studied as mood stabilizer monotherapy strategies. Now, mood stabilizer plus antipsychotic. Long-acting injectable paliperidone as an adjunct to any mood stabilizer is associated with a lower risk of relapse. Risperidone as an adjunct to lithium or carbamazepine has also been found to improve psychotic, manic, or depressive symptoms. The strategy of mood stabilizer plus antipsychotic is more suitable for patients responding to this strategy during the acute phase of treatment. Therefore, the choice of combination will depend on the agents used in the acute phase. Now, coming to the treatment of the depressive type, the acute phase and the maintenance phase. Now, first of all, the acute phase. The antipsychotic monotherapy, direct positive evidence is available for the use of paliperidone, risperidone, quetiapine, olanzapine, and haloperidol. Paliperidone improves depressive symptoms at lower doses. Risperidone is effective for both psychotic and depressive symptoms, and clozapine is found to be effective for suicidality. Antidepressant plus antipsychotics, this combination treatment is deemed to be the best possible treatment strategy. The combinations investigated are amitriptyline plus haloperidol, desipramine plus haloperidol, sertraline plus haloperidol, and risperidone plus any antidepressant. Now, depressive type maintenance phase. The only available evidence for maintenance treatment of depressive type of schizoaffective disorder is from a trial comparing olanzapine and ziprasidone. Although both agents improved depressive symptoms at 8 weeks follow-up, olanzapine had better and sustained improvements at 24 weeks than ziprasidone. Olanzapine also showed better adherence. Now, the prognosis and the predictors of outcome. The outcome in terms of clinical remission and functional recovery is substantially better in schizoaffective disorder than in schizophrenia. The predictors of poor outcome in schizophrenic disorders are poor functioning at baseline. Both occupational and social functioning should be assessed in terms of role responsibility and performance quality. The World Health Organization Disability Assessment Schedule may be used. Higher number and frequency of episodes. Persistence of psychotic and schizophrenic episodes beyond the period of presence of mood symptoms, presence of mood incongruent psychotic symptoms, especially first-rank symptoms. The role of number of life events before the onset was proposed to influence the outcome of schizoaffective disorder. A recent systematic review, however, reports lack of adequate evidence. My references are these. Thank you.
So I think it was an exhaustive presentation. So I would like to invite questions, comments, and clarification. Very important topic from examination point of view, clinical point of view, treatment point of view, research point of view. I think it has gathered a lot of attention and also recent controversy. So please, any doubts or clarification? For the schizoaffective ICD criteria, can you please go to the slide?
Yes.
ICD and आपने देखा ना शुरू में?
Yes.
Okay. ICD 11.
So ICD-10 has basically called this as an episodic disorder, and it has in this it has written that affective symptoms should be there and schizophrenic symptoms should be there. But ICD-11 has said that there should be a moderate to severe depressive episode, and all the criteria of schizophrenia should be met. Also, ICD-11 has told about a specific time duration. It has mentioned that 1 month of duration of symptoms should be present, and nothing like that is mentioned in ICD-10. Also, these specifiers have also been changed in Prevalence.
Basically, duration criteria of schizophrenia, जब तक नहीं meet होगा, 2 weeks of episode होगा, then not make any. Just they have written that 1 month on achievable. The specific psychotic symptoms, A2D, because in ICD-11 that A2D is So that specific they have taken off. Importantly, they have actually said that moderate severity of mood episode, which DSM doesn't say. DSM says it should be a major depressive episode or a manic episode. Severity they have not commented. But ICD-10 commented upon the severity. You should read between the lines. So the ICD-10 said it should be moderately severe. So 11 has taken things from there, but 11 has tried to go more near to DSM-5 by putting up that the diagnostic criteria should be fulfilled and 1 month duration should be fulfilled. So they have actually gone near to that. But 2 weeks criteria, they are not included. And this will be asked. This is a very frequent question which will be asked. Any other questions?
To be continuous specifier, it should be applied when symptoms fulfilling all the diagnostic requirements of schizoaffective disorder have been present for almost all of the course of the duration of the disorder during the person's lifetime. First onset, with periods of subthreshold symptoms being very related to the overall course. It has said that none of the remission symptoms they have lasted for more than 3 months or longer. If they have lasted for more than 3 months, then we would have called it as multiple episodes.
More or less, the episode, if it is extending to more than 1 year, we call it continuous. Now the whole point is, what about they are saying that we will say recurrent episodes if 3-month remission is there, but they say first episode is there and 1 month remission is there, we will say it complete full remission. So what about second and third? So if first episode is there, the specifier will go to the first episode. The specifier in full remission, how much duration they are saying?
So 3 months.
Yeah. Full remission.
So they are saying that in 1 month duration.
पीछे जाना, पीछे और पीछे यहाँ पे तो आपने फुल रिमिशन में बोला है 1 month.
Disorders have not been meant. Have not been meant to.
अगर मान लीजिए remission के लोग कह रहे हैं 1 महीने तक symptom नहीं meet हुआ है, fine. But for recurrence, they are saying 3 months का remission होना चाहिए. So what about second and third? So just check it out. Check it with the diagnostic criteria. If this lacuna is there, we can write a statement. We can actually write it in a letter to the editor, or we can publish it in any journal also. So, do you agree? It's, what do you consider schizophrenic disorder? Closer to bipolar or schizophrenia? Okay, next. So I think first year the comments. Usually the comments. Anything, any contributions? Prasad? There is yes.
When he came to us, he had got broadcast as like the main symptom. This is not a concurrent presentation, so we cannot call it as schizoaffective. Sir, as per ICD-10, it has stated that they can occur either simultaneously or within a few days of each other. So it differs from ICD-10, 11, and lesson 5. As per a few days, and he 2 years back, he gave it.
Different phase of the illness, you say.
Yes.
So, as per, can you diagnose, give it diagnosis of schizophrenic disorder?
So that time duration is not known. That in like कितने दिनों बाद उसको psychotic symptoms आए.
मान लो एक episode affective था, अभी currently episode is clear cut schizophrenia. That is what she is saying.
No, sir.
आप schizophrenic बोल पाएंगे?
Stated in the course and outcomes, so there could be 4 different outcomes.
As per
sir, sir, so sir, there could be 4 different outcomes. In one, after an episode is over, sporadic presence of schizophrenic symptoms can be existing. And in the second, after an episode is over, of either affect manic or depressive episode, then again sporadic schizophrenic symptoms are not present. Then in the third kind, there is only a monomorphous state, either depressive or manic, or then lastly, this can also be said as a transition phase, like after the occurrence of 2 or 3 episodes of schizoaffective. Basically the illness is transitioning from an affective to a schizophrenia. So that can kind of explain it.
But what you were saying is a completely different thing, that one episode of affective and another episode of non-affective, it might be a syndromal shift kind of a thing. If current episode is schizoaffective, then you schizoaffective.
So they reported around 3 depressive cases which is affected in sort of left-sided cerebral atrophy, and in right-sided cerebral atrophy.
Anything on the similar lines we have reported?
Yes, sir.
We have reported a case of like the Wilson in bipolar disorder. That was an entity which was picked up by the radiology by the MRI. The management, any comments on that? scale she has mentioned. There is no specific scale. So, sort of, after comments.
Comments in this schizophrenia as a diagnosis, practically it is very difficult to make, especially in recently such a long समय में देखेंगे तो आजकल तो बहुत कम पेशेंट में ऐसे क्लिनिकल केयरिंग काम होता है but overall we can have an idea. It's wise that is taking a lot of episodes and psychiatric episodes that Concurrent and psychosis obviously not something like we see normally in India. So patients of Bangalore होगा तो वो नहीं होगा लोकल एरिया में ही होता है. So we have to see वो जो सारे bizarre delusions होते हैं जो normally direct patient में नहीं होते हैं या फिर compensation होता है. So it is a diagnosis that is not very clear but
So we go for the first comment. I would say that I think Dr. Asta has managed to do a very tough job of digging into those three diagnosis systems and picking out those intricacies, symptoms, episodes, duration, which is not very easy. Schizoaffective disorder is a labile entity. At times we diagnose them as bipolar, at times with schizophrenia. Few patients will see that they represent both of the symptoms. Ideally, we should reserve this diagnosis for someone presenting with clear-cut schizophrenia and an affective disorder, and maintaining the syndromal criteria. Ideally, otherwise it will be very, very difficult for us to justify the diagnosis. Number one. Number two, regarding the management, you can see very less specific evidence regarding the management of schizoaffective disorder. So remember, there is a rule that when there is an absence of evidence is not evidence of absence. So whatever evidence you have, because of the scarcity of data, that doesn't mean that other stuffs will not work. We can generate our own evidence also in these kind of cases. In our own clinical experience, we can do that. And I think she presented it. Very good presentation. All the GRGs. Please take copy of this because this information, I think it is enough for you to at least answer questions in examination. As far as topic is concerned, the definition of schizoaffective disorders is actually becoming muddy with time because earlier on we had this problem is the definition of schizophrenia itself. So schizophrenia earlier, Schneider first time symptoms, they were given a lot of importance in ICD-10, not so much in DSM, and so it was easier to diagnose with DSM. But when you see the progression, mood disorders with psychotic symptoms like mania with psychotic symptoms, depression with psychotic symptoms, and mood disorders with symptoms of schizophrenia. So what do you exactly call symptoms of schizophrenia? So we had like first time symptoms, it was theoretically thought that these would be symptoms of schizophrenia. So if if in depression a person is reporting third person hallucinations, so you would say that it is more towards schizophrenia. Similarly, in mania, if he is reporting third person hallucinations or bizarre delusions, you would think that it is mania with not psychotic symptoms, but schizophrenia. Now, in the definition of schizophrenia itself, they have removed these bizarre delusions, they have removed third person hallucinations. Any hallucination is okay. So that definition for schizoaffective becomes difficult. How do you define symptoms of schizophrenia? Okay, and then the other symptoms, disorganized thinking. So flight of ideas, we know that if the flight of ideas progresses, it can present as a disorganized thought process. Incoherence is there. So it will be difficult to differentiate from disorganized thinking of schizophrenia. But as a clinician, it is difficult to put diagnostic criteria for schizoaffective schizophrenia. Mood disorder is a mood disorder with psychotic symptoms. It is easily schizophrenia. It is easy. But to define schizoaffective disorders on the basis of criteria, it is difficult. But as a clinician, you know that there are patients who you can say that they are schizoaffective.
You know that there, but we can't, on the current diagnostic system, we can't classify. The second thing is any diagnosis is made with any subtype, you are making it so that the management of the patient becomes, make a diagnostic criteria so that to serve your purpose, like you mix two things together and you make a diagnosis. So schizoaffective, again, a subset of patients where both of the symptoms are coexisting. The management is different from either mood disorders or from schizophrenia. We have to devise based upon, like, it is tailor-made to each patient, but we can't follow either of the guidelines. So that subset of patient is there. What specific diagnostic criteria we can specify so that the reliability does not affect, because the main thing is reliability. Because one psychiatrist can diagnose it as schizoaffective, the other will say it is mood disorder with psychotic symptoms. The treatment in most of the cases is like antipsychotic, mood stabilizers, antidepressants, depending upon the presentation. Okay, prognosis also depends midway between schizophrenia and mood disorders, depending upon the symptoms. That way it is difficult, but it's a concept that we need to understand. And it is different from comorbid schizophrenia with bipolar. That we should know that you can diagnose schizophrenia with bipolar also. Okay, so that is a different thing you can have. And so the time will tell. Two things, I think, schizoaffective disorders and mixed episodes of mood disorders. They are difficult to lay the diagnostic criteria. Good presentation you presented. Thank you.